Welcome everyone to this post-ASH video conference, the IMWG conference series. Thank you for joining us today, and I'm very pleased to welcome Dr. María V. Mateos from Salamanca in Spain, and Dr. Tom Martin from UCSF in San Francisco. Especially grateful to María V, who was traveling all day yesterday back from San Diego and is joining us today. So a special thank you to María V and Tom. A little bit of a shorter flight for you, but equally thankful for you to be taking some time after being gone for those number of days. So thank you to both of you. Next slide. Yes. So. Yeah, just go through those. Yes.
So we will have a video replay of the webinar. It'll be made available on our website early next week. You can find it under the publications and video tabs. Additionally, it will also be emailed directly to all those who registered for the meeting. And at the end of this webinar, we're going to have a survey pop up. It's a feedback survey. We really appreciate your feedback on the program. It allows us to build better workshops for you in the future. It would be greatly appreciated if you could take a moment to complete that survey.
All right. Okay, so this year was a very active ASH, obviously an in-person ASH, total attendance, which I'm told was most likely a record, 32,000 attendees. It certainly felt like that was the case, very busy, with over 28,000 in person and 4,000 or so virtual. The total number of abstracts this year, 7,000, and the number for myeloma, 1,000. These slides are full screen. There we go. All right. Yes. Over 1,000 myeloma abstracts, oral 136, plus the late breaking abstract, LBA, and the plenary abstracts, and we will be focusing on both of those. Those are considered to be among the best abstracts for the whole meeting. So out of the 7,000, the LBA and plenary are considered to be key abstracts presented to a very large audience, I think probably in the range of 5,000 people actually. And then there were 850 or so posters. A lot of different topics covered this year. There was some focus on real world data. We're not going to focus so much on that today. Also quite a bit of focus on equity, on access to drugs, these kinds of issues are very important, and we will touch on that a little bit at the end. But for the main part of our discussion today, we will focus on abstracts that really will have a scientific impact immediately and for the myeloma community overall for the foreseeable future. Some very important abstracts this year. Next slide. As always, we appreciate our sponsors who support our activities. This specific activity, Janssen Oncology, Karyopharm, Sanofi, and Takeda. Thank you so much. Next slide. So the first two slides focus on what we call frontline therapy, the therapy for newly diagnosed multiple myeloma, and in this case here you can see who are eligible for autologous stem cell transplantation, and this was the results of a trial called the Perseus trial, supported by the European Myeloma Network, EMN. And this particular study was looking at 4 agents: daratumumab, bortezomib, Velcade, lenalidomide, which is Revlimid, and dexamethasone. So DARA, BRD, versus VRD alone in patients with newly diagnosed myeloma. Next slide. And so this shows you the treatment protocol. And so patients were randomized to either get just the 3-drug triplet, the VRD, or with the addition of the daratumumab, which is the anti-CD38 monoclonal antibody that we have been using in many different regimens these last several years. Patients received 4 cycles of that, autologous stem cell transplant, consolidation with 2 cycles, and moving on to maintenance with either Revlimid or daratumumab plus Revlimid, making close note of the status of minimal residual disease, MRD, had MRD negativity being achieved at 10 to the minus 5 or 10 to the minus 6. Next slide, please. And so giving the immediate results that we are seeing so far at approximately 4 years of follow-up, what we're seeing is that the length of the remission, the progression-free survival, is significantly better with the 4-drug quad combination of Dara VRD, 84.3% at 48 months versus 67.7% with the VRD at that 4-year time point. Next slide. This correlated with an overall increase in the level of complete remission, either complete remission or stringent complete remission, in which case the bone marrow plasma cells are negative and the free light ratio is normalized. You can see that complete remission, 87.9% versus 78.1%. Over to the right with all these various arrows, you can see that across the board in the different subgroups of patients related to age and race and stage and cytogenetics, there was a shift in favor of the 4 drugs versus the 3 drugs. Next slide. Now, looking specifically at the achievement of MRD negativity, and this is testing of the bone marrow to see if any myeloma is left, looking at sensitivity at 10 to the minus 5 or 10 to the minus 6, you can see overall, again, significant benefit of the 4-drug versus the 3-drug, and then double checking at 1 year, at 12 months, again, sustained MRD negative, significantly more with 4-drug versus 3-drug, and obviously quite impressive numbers, over 60% MRD sustained in the quad arm. So very impressive, really. Next slide. And so overall, pretty clear that the Dara VRD is superior to the VRD in terms of the length of the remission, the PFS, in terms of the depth of the response, CR and MRD negative. There were no particularly unusual safety signals, as one might expect with these regimens, which have been used for some time. And so these data really do support the 4-drug as a potential new standard of care for transplant eligible patients. Next slide. Just, I think we do have, obviously it's early days, but the overall survival trend obviously also supports the 4-drug versus 3-drug at this point. Next slide. So, oh yes, I guess there's no Q&A slide there, but so María V, what is your take on this? Obviously, the fact that the major benefit was seen looking at the MRD levels is something that was emphasized by the introduction to this the talk by Peter Borges. So what is your thinking about this study?
Well, as you pointed out, Brian, I think that this is excellent because this is the confirmation of the phase 2 Griffin study that your colleagues in the US conducted. But here, this is a phase 3A trial in which the primary endpoint was progression-free survival, and the primary endpoint was met, and it is a significant benefit in progression-free survival, I would say, for the whole package of treatment, including daratumumab, not only as part of the induction, but also consolidation after autologous stem cell transplantation, and even as part of the maintenance, Dara-Len for 2 years. For me, it is very relevant, of course, the progression-free survival, the complete response rate. But for me, it is very important the minimal residual disease negativity rate, because overall it was 75%, but the minimal residual disease negative sustained at 1 year was almost 65%. From my point of view, this means that many patients will reach 2 years in minimal residual disease negative, and these patients will stop Dara as maintenance after 2 years of maintenance with the Dara-Len, will have the opportunity to continue with the Len alone. And these patients, in case of loss of the complete remission or loss of the minimal residual disease negative, can resume again daratumumab. So in addition of having a new standard of care for our patients with multiple myeloma transplant eligible, we are introducing something in which we've been working for many years, response-adapted therapy. And this means that the patients maybe don't need to receive Lendex plus Len plus daratumumab as continuous therapy until progression of disease. And for me, these are the main take-home messages. Of course, we have to wait in order to see the benefit in overall survival, but this trial definitely is something that can change our treatment for patients with newly diagnosed multiple myeloma transplant eligible.
Yeah, thank you so much for that. What is the reality of potential access to this 4-drug combo in Europe? What do you expect to happen if this is moving forward? Can this actually be feasible in many countries in Europe? What do you foresee happening?
Yeah, I have to say that in Europe and in majority of the European countries, Dara-VRD as induction and consolidation after transplant is a reality right now, because Dara-VRD was approved, but in Europe, lenalidomide is generic, and lenalidomide is cheaper than thalidomide, and it does not require to do any paperwork. So we are already using Dara-VRD, but only as part of the induction and consolidation. So what it is pending is the approval of the maintenance part, and based on the progression-free survival, based on the minimal residual disease negativity rate, and based on the possibility of practicing response-adapted therapy, I think that it would be quite useful for us to get the approval for the whole package.
Wonderful, wonderful. Okay, so Tom, your reaction and the impact in the U.S.
Yeah, so I completely agree with everything that María V said. This is confirmation that the original study that we did, the Griffin study, results were validated. Basically, with Griffin, we have been using quad therapy for most people up front, but this will change the label on daratumumab, that this will be an approved quadruplet, and thus hopefully all insurers will approve this as frontline therapy. The difference between Griffin and this study for us in the US is Griffin actually stopped the daratumumab and the lenalidomide at 2 years. People could continue lenalidomide if they wanted. This goes until progression, but like María V said, I love the fact that they randomized people, those that were MRD negative, to come off one of the drugs, daratumumab, and to continue just len, where the other arm's going to continue daratumumab and lenalidomide. So this will lead, I think, for us more information on what is the best randomized in randomized fashion, what is the best maintenance strategy and for how long you need to do maintenance. But honestly, for patients, et cetera, this study is going to show that people getting a quad, then a transplant, and then consolidation and maintenance with daratumumab, they're going to likely be in remission for 7 to 8 years from primary therapy. That's pretty amazing. That's the only treatment they're going to need for the first 7 to 8 years as they're getting therapy. And some people may not relapse.
Exactly. This, I think it is really practice transforming and will have a huge impact for patients. So absolutely. So let's go forward and take a look at the other trial. Somewhat similar, this trial, also from the European Myeloma Network, which is really showing its strength at these meetings, really the ability to do these large randomized phase 3 trials. In this case, it's atuximab instead of daratumumab and carfilzomib instead of Velcade. So looking at the 4 drugs is atuximab, carfilzomib, lenalidomide, and dex versus the 3-drug carfilzomib, lenalidomide, and dex. Next slide. It shows the schema, somewhat similar, but it has some different elements: 4 cycles, transplant, 4 cycles, and then what they call light consolidation. So a little bit different. And so MRD measured post-induction and post-transplant consolidation and the light consolidation. Next slide. And again, and the numbers are rather similar. At the 10 to the minus 5 level, 77% versus 67%, 67% versus 48%, 10 to the minus 6. So again, significant benefit at the MRD negative level. Next slide. And across the board, benefit and using the NGS method. Next slide. And so the one thing that they did emphasize, and this does relate to the use of the carfilzomib, the Kyprolis, versus the Velcade, is the impact in the high-risk setting. And they did make note of patients with 2 or more high-risk features showing significant benefit with the 4-drug versus the 3-drug. And so I'll be interested in María V and Tom's thoughts about the interpretation of that in this particular trial. Next slide. And so conclusions very similar. 4 drugs are better than 3 drugs. A tolerable safety profile. 10 to the minus 6 is very informative. They did not have data on the 1-year MRD negativity, the systemic MRD data yet. They will be having some longer follow-up. So, Tom, I'll start with you next. So what is your take on this study, particularly in comparison with the Perseus study?
Yeah. Sure. Both studies I really enjoyed listening to and seeing the results of both studies. And I think both studies really form the basis that we believe quads are better than triplets. This study is a lot less mature than the Perseus study, right? So 24 months of follow-up versus twice as much, 4 years of follow-up, essentially. And so therefore, we really only have MRD data from initial evaluations. We don't have a PFS data. I will say, so to go at your point, Brian, about the high risk, in the US, some people would choose Dara-RVD as initial therapy for non-high risk and would potentially do KRD in the high risk. That's what the practice in the US is somewhat bad, mostly because CD38 plus KRD has not been approved by most insurances just because of cost. So you choose one versus the other. I think these data, in my mind, show that I probably would choose DARA-RVD versus just KRD without a CD38. But if I have somebody that has double, what we're calling double hit myeloma, I would love to try to use these data to get insurers and NCCN guidelines to approve the use of CD38 plus KRD as frontline therapy and the real high risk, the double, the double hit patients. So I hope this is going to increase our ability to use CD38 plus KRD in the frontline setting, but I would probably just do that in the patients that had truly real high risk disease.
Right. María V, your reaction?
Yeah, my reaction is also very positive, although I completely agree with what Tom said. This study is more immature, and honestly, I would like to have seen a progression-free survival curve, but this was not possible. And the minimal residual disease negativity rate is impressive. So I think that Francesca had the opportunity in front of a very big audience, in front of all members of the American Society of Hematology, to put in context the value of the minimal residual disease in myeloma. And for me, this is extremely important. And in addition, as you pointed out, this study has been conducted by the European Myeloma Network in many European centers, and the MRD assessment was centralized. But this means that this is possible. So I can consider that this trial, also from the political point of view, is very positive in order to move forward to reach minimal residual disease and myeloma as an important endpoint. And we have to wait, but I can imagine that the outcome in the future for these patients, or almost 80% of the patients achieving minimal residual disease negative, the outcome will be excellent. But I have to say that in contrast with what Tom said, for the changing in the practice in the US, in Europe, it is going to be much more difficult to incorporate carfilzomib as part of the first line of therapy, because you know that until now, the phase 3 clinical trials trying to put carfilzomib in the first line of therapy have not been positive. And this is the reason why here in Europe, carfilzomib is not approved. But it's true that I have just received an email, and the idea is to put together all data from all clinical studies that we have with carfilzomib in the first line of therapy in combination with the anti-CD38 monoclonal antibodies, in order to go to the authorities in order to see if it is possible to get the approval. Because it's true that isatuximab, in this case, KRD, in patients with high risk, but especially in the patients with the double hit, 2 or more high-risk cytogenetic abnormalities, the MRD negativity rate was 77%. And this is what patients with high risk need to reach minimal residual disease negative, because this is the parameter able to overcome the poor prognosis. So this would be my take-home message. And I would say that much more data from the ESCA study will be coming in the next congresses.
Yeah, absolutely. Thank you so much for that. I do agree that this study, as well as the other study, really put the value of MRD testing into full focus to the broad ASH audience. And right at this time, as negotiations are ongoing with the FDA and on the European side with EMA, I think it is quite helpful to have this clear value of MRD testing in the assessment broadly demonstrated. So I think it was quite important to have that happen at ASH this year. So we're going to move forward. The next abstracts, we are going to be discussing them in a little less detail so that we can get through the program today. But the next topic is the results from the Spanish team, María V, that you know very well, particularly with Bruna, but also Naomi, working together with the rest of the Spanish team members. Next slide. So we're going to touch on two of the several abstracts that came from Spain this year, from Salamanca and Pamplona. Next slide. So obviously, I think what is clear that the analysis of the GEM trials has illustrated with many 1,759 MRD assessments the value of sustained MRD negativity, just exactly what we've been talking about, the stability of MRD testing, the sustained MRD testing is clearly a powerful guiding endpoint for us to aim for. Next slide. And this outperforms any other kind of testing that you might care to conduct. That really MRD is something which we need to pay attention to. Next slide. But the unmet need is that the MRD testing requires, certainly for sustained MRD, multiple bone marrow aspirate testing. And so there's tremendous interest, and this has been a focus of the assessments by the Spanish teams, to look at better routine implementation of MRD testing into routine practice. Next slide. And so Bruno presented the complementary value of different tests using peripheral blood, looking at plasma, cell-free DNA, and also serum protein testing. So what Bruno was presenting was the results of an immunomagnetic bead approach, which he has applied to concentrate the myeloma cells for blood assessment. Next slide. And so this is a test which has been called blood flow. So this is a method which takes a large blood sample, concentrates the myeloma, and uses the normal next generation flow method to assess the blood sample. And this has provided valuable MRD assessment at the cellular level, looking for myeloma in the blood. And you can see here that if you're MRD negative using this blood flow technique, that does correlate with a longer remission, a longer PFS. Next slide. And this shows again using restricted samples, looking at NGF, again, paired samples. There's a value in being a double negative versus positive or mixed positive. Next slide. And so the next question is, how do you balance the use of the cellular testing with blood flow, with mass spectrometry? And the idea is that they are definitely complementary. Next slide. I'm just going through these quickly so that you can see the data. And here, looking at the combination of MRD testing in the blood using blood flow, and then using mass spectrometry, obviously being negative with both of those really enhances the value of negativity and sustained negativity, with patients having significantly longer progression-free survival. Next slide. So double negative MRD detection in the blood, very positive way forward with blood flow and QIP mass spectrometry. Next slide. And so basically illustrating that using blood testing can potentially be a more practical way to move towards bringing MRD testing into the clinic and allow us to assess our patients in this accurate way, but in a more practical way for the patients. And so, María V, do you see this as the reality, as the practical way forward? I know that the blood flow method is not necessarily such an easy method to broadly implement, but certainly does provide that accurate assessment.
Yeah, sure. I think that this is an interesting way and an interesting space in which we have to enter because we know measurable residual disease and detectable measurable residual disease is maybe the most important prognostic value factor we have in myeloma. But the main problem is we have to go to the bone marrow. And especially now with the quadruplet combinations we have just evaluated, many patients will be in minimal residual disease negative, and we've seen how the kinetic is extremely important. And the evaluation of the measurable residual disease over time is extremely important. And it is not possible to go to the bone marrow every 3 months or every 6 months, even because this is a painful technique and because of the logistic resources and so on. So I think that this is the reason why we have to investigate on the minimal residual disease in the peripheral blood. And I think that this is the result. And in Spain, as you pointed out, we are doing next generation flow in the peripheral blood, and is the next blood, or the next generation, the blood flow, that this is the term for the next generation flow in peripheral blood, and mass spectrometry. What are the differences? Of course, we know that the blood flow is going to count plasma cells, aberrant plasma cells in the peripheral blood. And mass spectrometry is going to evaluate or to detect the molecular mass of the monoclonal component. So I think that both are complementary, as it was demonstrated in this study. And if you see, well, the predictive positive value for blood flow is extremely high, and the negative predictive value for mass spectrometry is extremely high. So I think that both techniques are very, very complementary. And from my point of view, the first important approach is if we go to the peripheral blood and we see that the blood flow or the mass spectrometry are positive, it is not necessary to go to the bone marrow. We have to wait because the bone marrow is going to be positive. This is as first step, but in the future, I think that will allow to monitor the absence of minimal residual disease over time in a very simple way, and this will allow to do early intervention, as we previously seen in the Perseus study, in case of reappearance of the minimal residual disease. But now, if we do a bone marrow annually, it's true that we are going to lose the probability of early detecting the relapse in many patients. And with these techniques, evaluating the measurable residual disease in the peripheral blood, we are going to early detect very early relapses in many patients. So this would be my main comment. And also just a brief comment to the circulating tumor cells that can be evaluated by flow cytometry in the peripheral blood, and those patients in which the circulating tumor cells, for example, in smoldering myeloma, remain stable or they are not detectable, we have to know that the progression-free survival is going to be very long. And whilst if the circulating tumor cells do evolve over time, we have to be pending because maybe we can complement circulating tumor cells with the 2020 model in order to refine and in order to optimize the risk of progression to myeloma. So I think that all these techniques in the peripheral blood have to be implemented in the clinical practice in the future, because we know that both flow, as you said, it is required 50 cc's of peripheral blood, and mass spectrometry, it does require of the technology in order to do. But I think that both technologies will be incorporated in the upcoming years or in the upcoming months, at least in the academic centers.
Thank you so much for this, María V. Yeah, so I think that you did emphasize the one point, which for the blood flow, for the cellular testing, the positive value, in other words, the finding of the myeloma cells is very predictive. In the case of mass spectrometry, having a negative result is obviously very, very powerful and indicative of a good outcome. So in the one case, finding cells is bad, having a negative result is good. So Tom, I think what I'm going to do is skip forward to the next abstract, which focuses on, so here is a picture of the Spanish teams. such a busy group of teams, María V, and
Yes.
so many women working in your teams. I love to see that, right?
Yes.
It's wonderful. Next slide. So, Tom, we were thinking about mass spectrometry. This is a study from Chicago focused on what is the impact of mass spectrometry as part of the phase 3 Atlas trial. Next slide. And the study here was relatively straightforward. Within this trial with KRD and KRD versus lenalidomide, they looked at the impact of measuring the myeloma protein level using the very sensitive MALDI-TOF mass spectrometry method. Next slide. And also had flow cytometry MRD testing. Next slide. And they were able to show, and they had results at different time points, but for them, the most predictive was to look after cycle 18, and this was associated with superior progression-free survival if the mass spectrometry was negative. And so this is one study that is showing the independent value of the mass spectrometry. Next slide. And this shows you what you can see is rather a similar pattern using next generation MRD testing. Next slide. And then also using next generation flow. Next slide. And so double MS and MRD testing, as we've just been talking about, is doubly favorable. And so really another study illustrating the complementary use of these testing techniques. And it definitely does seem like it is the way forward for the future. Next slide. Oh yeah, I guess the next slide is the next presentation. So Tom, what was your take, particularly focused on the value of the mass spectrometry? Maybe you could comment a little bit more about how you see mass spectrometry evolving as an available technique in the US and globally, actually.
Yeah, so I'll try to put it a little bit into context in that the studies that we're looking at this are mainly frontline studies. And like with the Perseus study and the Ischia study, the studies in which we're having great success in really reducing the myeloma burden, the question then becomes, is what's the best test, or which tests can we combine to get our deepest assessment of where the myeloma burden exists? How low is the myeloma burden? At the current time, obviously the SPEP and the assessment of M protein or light chains, it's not a great assessment of myeloma burden or what's left of the minimal residual disease. So we have to get a deeper assessment. So this mass spec allows us to actually identify a much lower level of protein in the blood. So where we would be in a CR from our prior tests, we're still going to be able to detect the myeloma protein for multiple additional cycles of therapy. And we get to a very low level by mass spec, and it's mass spec negative. We know that really there's just minimal residual disease left. And so that's a great thing that we can do it through a simple blood test. The question then becomes, what's complementary to that? Do we have to do a bone marrow then? Do a bone marrow to look at flow cytometry of the bone marrow to see how many myeloma cells out of 1 million are still in the bone marrow? That's something we could do for sure. And those have been shown to be complementary. Or can we do it with this peripheral blood flow cytometry test? The Spanish group, nobody does it better than the Spanish group. That is for sure. And the data from Bruno's lab's amazing. But I'll say that the blood flow actually takes 50 mLs to do. So that's right. 10 vials. That's a lot of vials to do. So we definitely need to have an even better way to do it with a lower volume of blood. But that blood flow is probably, I would in my opinion, almost as good as a bone marrow biopsy. And it certainly would be able to, for us, decrease the number of bone marrows that we're doing for surveillance. Like María V said, we can do surveillance with the mass spec in the peripheral blood flow and just reserve bone marrow biopsies for very infrequent measures to confirm if they're MRD negative. So this is for sure the wave of the future. It's going to spare a lot of bone marrow biopsies, thankfully, for the patients.
Right, right. And I think it's going to take some time. This is something that's not going to happen overnight. I think that we're looking toward the future where we can have this idea of shifting from bone marrow to blood, but we need confirmation in a variety of different settings and the like. But I think it is very encouraging for everyone, all of us, including patients, obviously, that blood testing can be feasible to have accurate information to guide treatment decisions. Next slide. Yeah, so next slide. Yeah. So just what we've been talking about, further prospective studies are definitely needed. Next slide. Okay, so now we're going to focus a little bit on the studies from Iceland, and there was quite an emphasis on the ISTOP-MM study that Iceland screens, treats, or prevents multiple myeloma, multiple abstracts. In fact, 3 of the abstracts presentations from Iceland were selected as, and the presenters received awards from ASH, actually, for the presentation. So it was actually pretty remarkable that the data from Iceland was highly respected and appreciated. So I'm going to have a bird's eye view of this Iceland project and some of the main aspects that were topics, important topics of discussion at ASH this year. Next slide. The important thing to realize that at the present time, less than 10% of myeloma cases are diagnosed at an asymptomatic stage. And so screening for earlier disease could really shift the needle towards diagnosing myeloma much earlier. And so one of the questions is, if you screen for myeloma, what is the impact in terms of possible earlier diagnosis? And so a lot of interest in that. Next slide. This is the famous waterfall in Iceland. I can tell you that it's dramatically cold there and windy. You want to get back on your tour bus right away after looking at this waterfall. Next slide. Okay, this shows you the study that was conducted starting 5 years ago now. The screening test was initiated, and over half of the total population of Iceland, 54% of people in Iceland, agreed to have their blood tested to see if they had a monoclonal protein in the blood, to see if they had MGUS, smoldering, or active myeloma. And 29 patients from the screening actually did have myeloma. And then the rest were randomized, if positive, to no further follow-up, following standard monitoring guidelines, or to a much more intensive diagnostic and monitoring and treatment schedule. And so 3 arms to this randomization, but with very, very large numbers. Out of the screening, 3,543 new cases of MGUS were identified and randomized into the 3 arms. Next slide. Next slide, yeah. And so, so this just shows you overall what happened with the progression to smoldering or other disease entities, and then focusing on myeloma or things related to myeloma. When you're screening, monoclonal proteins are associated not just with myeloma, but other things, which can include Waldenstroms and lymphomas and things like that, which you see over on the left here. Next slide. But then the progression was looking at what happens if you're looking to assess whether someone develops myeloma or not, if you're being watched closely or not being watched closely. And so they established a landmark to see what happens before or after the landmark. And I'll just keep going here so we can get to what is the bottom line. If you've been screened, leads to earlier diagnosis of myeloma and related disorders. Next slide. But the key point was, if you pick up the myeloma earlier, if you're in the screened population, what is the status of the myeloma? And this is what there was a big discussion about at ASH, is that the stage of the myeloma, the occurrence of the CRAB criteria. So you're looking at the purple versus the gray, so that the purple is in the screen population. And so the CRAB criteria with the purple was much less in the patients who were screened versus those that were not. And the indication is clearly that the disease is being picked up at a much earlier time point, which is an important discriminator before we have the outcome in terms of overall survival and a benefit from screening. Next slide. So, yeah, so just, I'm sorry, just go back again for one slide. I'm sorry. Yeah, just click forward on that. Yes. Click forward, yeah, let's go forward. Yeah, so I think that screening changes the clinical presentation of myeloma is one of the big takeaways here. Next slide. I'm just going to go through quickly because the results of this were pretty clear. Here you can see the psychological outcomes. Despite what you might think, you can see if you look at the bar graphs on the left, anxiety and depression did not go up, they actually went down. People came into the clinic and were discussing their test results, and they were not anxious or depressed. If you look over to the right, in fact, they were satisfied, in fact, increasingly satisfied that they had had good answers and things were proceeding in a good way, so that there was not a psychological harm from the screening process coming out of this Iceland study. Next slide. Yeah, it does not increase depression, anxiety, or life satisfaction. Next slide. Okay, screening leads to earlier, not overdiagnosis. It changes the clinical presentation. Next. How does it affect survival? We're relating to see that. Is it worth it? It does change the face of myeloma. And so, María V, maybe we can start with you quickly. What do you think about this in terms of how screening will proceed? Do you think that screening will indeed be the way forward?
Well, personally, I consider that the answer should be yes, although it's true that we need maybe longer follow-up in order to see more benefit. For me, I think that it is very clear, and I like very much screening changes the clinical presentation of myeloma. And this is what we've been defending in all of our clinical trials conducted in high-risk smoldering myeloma, in spite of many debates. For me, the major benefit is the benefit the patients can get if they are early diagnosed, and we can prevent or delay the development of CRAB criteria. And this has been demonstrated in this project. And for me, this is valid and extremely important in order to plan should we go to screening to the population. But I realized that the decision of moving to screening to the population, like in Iceland, over 40 years, this is, I would say, a even political decision in which many stakeholders are involved. But from my point of view, I think that this project is extremely important. And if today we can't say we have to do a screening to all population older than 40 years. I think that this is something that maybe we'll do in a few years when this study will report benefit in overall survival. For me, it is extremely important. The first sentence that you put in your slide, less than 10% of myeloma cases are diagnosed at an asymptomatic stage. And I think that this less than 10% should increase to at least 80 or 90%.
Right, absolutely, absolutely. So Tom, I think the key point really is that we're starting to see the clear value of screening, but it's the practicality of this that is excuse me, is a question.
Yeah, I agree.
Tom?
The devil will definitely be in the details
Yeah.
on how we recommend this. But one thing I want to point out,
Yeah.
and you pointed out, Brian, in the beginning, is in the population of Iceland, 54% of the people said they would participate in this research study, which is pretty amazing. And 5% of those screened had MGUS. And so just the enthusiasm and the participation is amazing, and that's how we make advances in myeloma, is by patients, participating in some of these trials, so that we can figure out what is the best strategy in all aspects: initial screening, early treatment for relapse, et cetera. That's why we've had so many benefits in multiple myeloma.
Absolutely, absolutely. And so I think there is a lot of excitement thinking to the future that this can be a way forward. And I know now there is a big emphasis in thinking about how could, in fact, screening be practical and feasible. And so there are a number of ideas that relate to that. And excuse me, we'll see how this moves forward. Next slide. Yeah, we'll skip that one, yes. Okay, so we're kind of running out of time, but one of the big aspects at ASH this year was not just the focus on the immune therapies like CAR T cells, bispecifics, trispecifics, but what are the correlates of that? What are the multi-omic assessments of patients undergoing these immune therapies? What are the cytokine profiles, and what are the patterns that correlate with patients who benefit from these types of therapy like CAR T versus patients who might become resistant to CAR T therapy? And so a lot of interest, and this is just one example from Mount Sinai in New York, of a study looking at cytokine profiles and other immune parameters that relate to outcomes with CAR T. So let's just quickly go through this. Next slide. The determinants of early relapse, looking at the different patterns. Next slide. You can just give me the next slide, please. Yeah. Okay, so this shows what happens in the peripheral blood. You can see the CAR T cells across the top. You can see the other cells that are occurring, the dynamics in the peripheral blood, the landscape after CAR T infusion, looking at T cells, myeloid cells, B cells, and in addition to the CAR T cells, which are the little blip across the top, extending out over 10 weeks and beyond. Next slide. And so this group looked at the peripheral blood and looked at the patterns of different cells, the CAR T expansion, and different things that were occurring in patients who were having a PFS of greater than 18 months versus not. And they did establish some important differences if we just move forward. Sorry to go through this a little bit fast. Next slide. Yeah, you can see the clear difference between those who did have 18 months PFS versus those that did not. Next slide. The key thing is that there were clear patterns indicating the activated or the stimulatory patterns associated with the longer responses, where versus the regulatory or immunosuppressive pattern associated with lesser benefits. So very, very interesting to look at these different patterns. Next slide. And what they pointed out is that two endogenous populations, the CD18 naive and the MAIT group, significantly higher in those with the longer PFS of 18 months or more. And so a lot of interest in this as an example of predictive patterns. Next slide. Yeah, pretty obvious differences. Next slide. Yes, MDSC cells were significantly increased in patients with the shorter PFS. So patterns associated with shorter, patterns associated with longer. Next slide. And there are a lot of details in this study, as well as many of the studies that were presented at ASH this year, looking at single cell analysis, looking at all kinds of different elements in patients. Next slide. Yeah, so the expansion of activated CAR T cells and higher serum levels of cytokines with T cell proliferation, the IL-12, CD27, 28, correlated with longer PFS, and the bone marrow microenvironment, cell-mediated CD8 naive, and MAIT were observed in patients with longer PFS, immunosuppressive correlated with the shorter PFS. Next slide. Yeah, so anyway, this is an example of looking at this kinds of correlations. Tom, I know that you're particularly interested in CAR T therapy. Did you feel like this was a kind of a helpful start to get a handle on benefit versus lack of benefit?
Yeah, so I think the data that was presented there from Mount Sinai was presented by several other groups at this meeting. Right. And we've actually also found similar data here at UCSF. There are ways for us to try to interrogate why CAR T cells are working. We can interrogate the myeloma cell, which we'll talk about in a second, but we also can interrogate the immune cells that are in the bone marrow and are in the blood that are trying to help the CAR T cells work. So when you have a product that's manufactured and when you give it back to a patient that has these activated T cells that have, they call it central memory type or CD8 naive cells, those are cells that actually are better at killing the multiple myeloma cells. And so if you can expand that population when they're infused into the patient, that patient's going to have a better results. And what we've actually seen in some of our experiments is that the longer those cells persist too, and you saw that kind of that brownish bar, the
little bar across the top, yes.
Yeah, the ones that have the CAR Ts, the later on are likely the ones that had the best response. We're trying to get the CAR Ts to be more persistent. On the other side, our immune system in our body wants to try to not have too much of activation and some suppression, and the cancer stimulates this immunosuppressive effects. And so MDSCs or T regulatory cells or cytokines that tell the T cells to calm down or rest, those are associated with not having such a good response after the CAR T. So these are really important lessons for us as we move forward on how we're going to manipulate and make CAR T cell therapy better in the future. And we're going to be able to do that. We're going to be able to innovate much better than we have in the past with autologous transplant and with other therapeutics with CAR T cells to try to increase the chance that those T cells are going to be activated and that we're going to be able to get rid of some of these immunosuppressive cells before we do the CAR T cell, which is amazing. Now, I'll just mention one thing about what we've found at many sessions at ASH about the myeloma cell itself is we found that there are mutations that decrease the expression sometimes of the target on the cell surface. You know, at baseline, there's probably more There's more mutations that actually decrease the number of receptors of GPRC5D on the cell surface than BCMA. So that might be a more likely scenario. But there's also mutations in the protein so that when the receptor, the antibody binds to that protein, it binds to a specific spot. And there can be mutations in that binding domain that changes it so the antibody or the CAR T doesn't bind as well anymore. So these are things we're going to have better tests for ahead of time to actually be able to select the best therapy for each individual patient.
And then, as you know well, Tom, how those will change over time. And as patients sequence through these different therapies. So we just have a moment to have some additional takeaways from ASH. María V, besides these things that we have talked about, was there anything else that struck you from ASH, any topic or abstract that you thought was particularly important for you?
I would like to emphasize, especially for patients that as in the US, the bispecific monoclonal antibodies, teclistamab, talquetamab, elranatamab, are already in the market. We've had the opportunity to see real-world data. It's important to mention that in principle, some efficacy data looks a bit inferior in comparison with the clinical trials, but it's important to remark that the majority of the real-world data we've seen, well, approximately 50-60% of the patients would have not been included in the clinical trials because they didn't meet the inclusion criteria, because the population treated in the real life were more heavily pretreated with much more extramedullary disease, renal impairment, and so on. So for me, it's important, this is the real world data that we have to generate and to know this data, and other abstracts focus on the optimization of the bispecific monoclonal antibodies. This is important for the patients, the infection management, to try to reduce the hospitalization, the possibility of using tocilizumab in a prophylactic way. So I think that all these abstracts, majority of them in the poster format, can be very useful in order to manage better our patients with myeloma in the era of bispecific.
Yeah, absolutely. Many abstracts that cover these topics, which are very, very important practical points. And Tom, some final thoughts from you?
Yeah, I'll just point people to two CAR T cell therapies that were presented. One, targeting GPRC5D. So BMS has a new CAR T cell therapy that targets GPRC5D. Susan Ball presented the abstract, and it included, over 80 patients. It shows that GPRC5D is actually a great target. Response rates were in the 90+% range, with CR rates being, upwards of 50%. And this worked in patients who had prior BCMA exposure, which is really important. And so patients who get a prior BCMA therapeutic can go on to, looks like, to a GPRC5D CAR T cell therapy. The follow-up is short, but it looks like the PFS is going to be, more than a year. We have to see how that all works out over time as we see more follow-up. But it was a very tolerable CAR, with grade 1 and 2 CRS as being the most common side effect, as well as cytopenias. So that was very exciting. And another BCMA targeted CAR, it's called ddBCMA, has shown a very impressive response rates, 100%. And the really important component in my mind, they're working now in together with the company Kite Pharmaceuticals to use Kite as a way to manufacture their cells. So now it's the company Arcelix and Kite have formed a bond, and we're hoping that this will increase the number of slots of BCMA CAR T cells that we'll have available for patients throughout the U.S. and hopefully a not too distant future.
A great point. The manufacturing capability in linking with Kite can make this quite powerful in terms of access to a CAR T, which seems to be very effective. So key point. One final word from me. I think it was intriguing, a very small study using teclistamab in high-risk smoldering myeloma a very small number of patients treated, but María V, you can say, make a small comment, 100% response rate, 100% MRD negative, a long course of therapy, but certainly intriguing to see that.
Yeah, sure. I think that this trial is exciting. The trial planned 24 months of treatment. My first comment is maybe it is not necessary 24 months of treatment.
Exactly.
Because if after 2 cycles all patients are in MRD negative and based on the safety profile, maybe this can be taken into consideration in order to reduce the number of cycles. And if this does work for high-risk smoldering myeloma, this would be excellent. I have to know that some trials are coming with bispecific monoclonal antibodies and even with CAR-Ts for high-risk smoldering myeloma. So I think that the situation is, is excellent.
Yes, this was intriguing, but 2 years really quite challenging. Yes. So thanks again to our sponsors, and so I'd especially like to thank Dr. María V. Mateos from Salamanca in Spain, and Dr. Tom Martin from UCSF in San Francisco, from taking the time to discuss these important abstracts from ASH and the takeaways, and hopefully this has been informative and useful for our listeners. And with that, I wish everyone a good day. Thank you again to the sponsors.
Thank you.
Thank you very much.